In previous courses as well as this course, you've learned that pain is subjective. During the first stage of labor, uterine contractions produce progressive cervical effacement and dilation, and as the first stage progresses, uterine contractions become stronger, longer, and more frequent. We must be able to assess and identify women who are in pain, and both non-pharmacological and pharmacological measures that are available to them. I also want to point out at this time for you to review Chapter 50 of the McQuiston book to also guide the practice in this topic. As the woman progresses through the first stage of labor, some nursing interventions include encouraging the woman's partner to participate, keeping the woman and her partner up to date on the progress, orienting the woman and the partner to the labor and birth unit, encouraging the partner's involvement with breathing techniques, keeping the perineum clean and dry. During the second stage of labor, focusing on supporting the woman and her partner in making active decisions about her care and labor management is critical. The primary rationale for directing women to push is to shorten the second stage of labor. Common practice in many labor units is still to coach women to use closed glottis pushing with every contraction. Shortening the phase of active pushing and lengthening the early phase of passive descent can be achieved by encouraging the woman not to push until she has a strong desire to do so, and until the descent and rotation of the fetal head are well advanced. During the second stage of labor, perineal lacerations can occur when the fetal head emerges through the vaginal introitus. The extent of the laceration is defined by depth. An episiotomy is an incision made in the perineum to enlarge the vaginal outlet and theoretically to shorten the second stage of labor. Alternate measures such as warm compresses and continual massage with oil have been successful in stretching the perineal area to prevent cutting. The midline episiotomy is the most commonly used in the United States. The application of warmed compressions is associated with decrease in trauma in the perineal area. Routine episiotomy has declined since literal usage has been discouraged. Anal sphincter laceration can occur during a midline episiotomy. Providing instruction and assistance with pain relief and partner assistance is guided during the second stage. During the second stage of labor, the moms are experiencing increase in apprehension or inability. You might also see a spontaneous rupture of the membranes, sudden appearance of sweat on upper lip, increase in bloody tin show, low grunting sounds from the woman, and beginning of involuntary bearing down in efforts. Nursing interventions during this stage focuses on motivating the woman and encouraging her to pull all her effort to pushing the newborn out. If the woman is pushing and not making progress, suggest that she keep her eyes open during the contraction and look toward where the infant is coming out. Changing positions frequently will also help in making progress. During the second stage of labor, an ideal position would be one that opens the pelvic outlet as wide as possible, providing a smooth pathway for the fetus to descend through the birth canal. During the second stage, nurses must provide continuous comfort measures, pushing only when she has the urge to do so, continuous fetal heart rate monitoring, providing brief and explicit directions during the stage, pain management, assessment of all vital signs, and encouraging delayed pushing for up to 90 minutes after complete dilation. The second stage of labor ends with the birth of the newborn. The maternal position for birth varies from the standard lithotomy position to sidelining. Once the fetal head has emerged, the primary care provider explores the fetal neck to see if the umbilical cord is wrapped around it. As soon as the head emerges, the healthcare provider suctions the newborn's mouth first, and then the nares. The umbilical cord is double clamped and cut, and when the first cries of the newborn, the second stage of labor ends. Assessment during the third stage of labor includes monitoring placental separation by looking for the firmly contracting uterus, change in uterine shape, sudden gush of dark blood, and lengthening of the umbilical cord. Examining the placental and fetal membranes for intactness is critical. You also need to assess for perineal trauma following the birth. Firm fundus with bright red blood trickling. Is there a boggy fundus? And is there dark blood clots related to retained placenta? Assessing for perineal lacerations and inspecting the perineum for conditions of episiotomy are critical during the third stage. The fourth stage of labor begins after the placenta is expelled and up to 4 hours after birth. This recovery period may take place in the same room where the woman gave birth or in a separate recovery room. Close observation is required to identify early recognition of hemorrhage, provision of comfort, and promotion of family attachment. During the first hour after birth, vital signs are taken every 15 minutes, and the woman's blood pressure should remain stable within normal range after giving birth. A decrease may indicate uterine hemorrhage. The pulse is slow, 60 to 70 beats per minute than during labor, which is associated with a decrease in blood volume following placental separation. An elevated pulse rate may be an early sign of blood loss. Respirations are between 16 to 24 and should be unlabored. Assessing fundal height, position, and firmness every 15 minutes during the first hour following birth. It needs to remain firm to prevent excessive postpartum bleeding. If the uterus is boggy, gently massage it until firm. Remember, if the fundus is displayed to the right of the midline, always suspect a full bladder. During this fourth stage, nursing interventions include providing support and information to the woman regarding episiotomy repair, applying ice pack to the perineum to promote comfort, assist with hygiene and perineal care, monitoring for return of sensation and ability to void. So, some non-pharmacological measures include hydrotherapy, ambulation, and position changes. Remember, continuous fetal heart rate monitoring requires that the mom remain in the bed. So I want you to consider that during this non-pharmacological decisions. It has long been the standard of care for labor nurses to first provide or encourage a variety of non-pharmacological measures before moving to the pharmacological measures. Non-pharmacological measures are simple, safe, and inexpensive. Many of these measures are taught in childbirth classes, and women should be encouraged to try a variety of methods prior to the real labor. Breathing techniques, or pattern breathing, are a positive experience for both the mom and the spouse or caregiver to try to relieve the pain. This should be encouraged by the nurse during delivery and before any pharmacological measure is used. Pharmacological measures include systemic analgesia, regional or local anesthesia, neuraxial anesthesia, and shift in pain management as women are more participating in active labor. Systemic analgesia used during labor include sedatives, hypnotics, narcotics, and nys-narcotics, and agonists and antagonists. In McQuiston, Table 50.1 lists analgesics used during labor, delivery, and postpartum. The most important complication associated with the use of this class of drug is respiratory depression. Therefore, women given these drugs require careful monitoring. Opioids given close to the time of birth can cause CNS depression in the newborn, necessitating the administration of Narcan to reverse the depressant effects of the opioids. Systemic analgesics are administered IV. Nearly all medication given during labor cross the placenta and have a depressant effect on the fetus. Regional analgesia provides pain relief without loss of consciousness. It involves the use of local anesthetic agents with or without opioids to bring about pain relief or numbness through the drug's effects on the spinal cord and nerve roots. The routes for regional pain include epidural block, combined spinal epidural, local infiltration, pudendal block, or intrathecal. Epidural anesthesia for labor and birth involves the injection of a local anesthetic agent and an opioid analgesic into the lumbar epidural space. The anesthesiologist conducts this using a small catheter through the epidural needle to provide continuous access to the epidural space for maintenance of analgesia throughout labor and birth. An epidural is contraindicated for women with previous history of spinal surgery or spinal abnormalities. Ensuring that the woman avoids a supine position after an epidural catheter has been placed will help to minimize hypotension. Combined spinal epidural analgesia involves inserting the epidural needle into the epidural space and subsequently inserting a small gauge spinal needle through the epidural needle into the subarachnoid space. An opioid is then injected into the space. Ambulating during labor provides several benefits, and when a mom receives a spinal epidural analgesic, she is allowed to do this. Not only does it help control pain better, but it may shorten the first stage of labor. PCA analgesia involves the use of an indwelling epidural catheter with an infusion of medication and a programmed pump that allows the moms to control the dosing. The moms have a sense of control over her pain and reach her own individually acceptable analgesia level. Local infiltration involves the injection of a local anesthetic such as lidocaine into the superficial perineal nerves to numb the perineal area. This technique is done by the physician or midwife just before performing an episiotomy. Pudendal nerve block refers to the injection of a local anesthetic agent into the pudendal nerves near each ischial spine. It provides pain relief in the lower vagina, vulva, and perineum. A pudendal block is used for the second stage of labor, an episiotomy, or an operative vaginal birth with outlet forceps. A spinal or intrathecal analgesic involves injection of an anesthetic cane agent like lidocaine with or without opioids into the subarachnoid space to provide pain relief during labor or C-section. Adverse reactions for the woman include hypotension and spinal headache. So I want you to consider what is the nurse's intervention prior and evaluation during this pain, while the mom is receiving this medication. Although pain relief is rapid with this technique, it is limited by the narcotic's duration of action. which may only be a few hours. General anesthesia is typically reserved for emergency C-sections when there is not enough time to provide spinal or epidural anesthesia. It can be started quickly by the anesthesiologist, and it can be administered by IV injection. In the previous slides, we talked about false and true labor signs. During the first stage of labor, depending on how far advanced the woman's labor is when she arrives, the nurse will determine assessment parameters of maternal fetal status and plan accordingly. Nursing care during this stage will include taking an admission history and completing a physical assessment of the woman to establish baseline values. Some key things you have to remember is estimating date of birth, fetal movement, parity gravida, time frame in previous labors, characteristics of contractions. The nurse usually first comes in contact with the woman either by phone or in person and needs to ascertain whether the woman is in true or false labor. She needs to be admitted or sent home. Upon admission to the labor and birth suite, the highest priority include assessing fetal heart rate, assessing cervical dilation, effacement, and determining whether membranes have ruptured or are intact. A maternal health history is the first thing that should be done at the time of the birthing suite. Other information that is collected include the prenatal record, including estimated date of delivery, Rh status, group B beta strep, past pregnancy, diabetes, hypertension, and other critical information. Be sure to observe the woman's emotions, support system, verbal interaction. This psychosocial information provides cues about the woman's emotional state, culture, and communication system. It is important to acknowledge and try to understand the cultural differences in women with cultural backgrounds. Attitudes toward childbirth are heavily influenced by the culture in which the women have been raised. At the time of her admission, typical laboratory studies are done, such as urinalysis and CBC. Blood typing and Rh factor is also necessitated, as long as hepatitis and group B streptococcus and HIV testing. We previously discussed group B streptococcus. I'm not going to discuss that here. If her HIV status is not documented, the woman being admitted to the labor unit should have a rapid HIV testing done to reduce perinatal transmission. Women who are HIV positive are given ZDV over an hour, and then a maintenance infusion 1 hour after birth. The newborn is given ZDV orally after delivery and continued for 6 weeks. After the admission assessment is done, as well as lab, and the labor is progressing, you need to assess women's knowledge and experience and expectations of labor. Blood pressure, pulse, and respirations are assessed every hour during the latent phase of labor, unless the clinical situation dictates. During the active and transition phases, they are assessed more frequently every 30 minutes. The temperature is taken every 4 hours. Vaginal exams are performed periodically to track labor progress. This assessment information is shared with the woman to reinforce that she's making progress toward the goal of birth. Uterine contractions are monitored for frequency, duration, and intensity every 30 to 60 minutes during the latent phase, and every 15 to 30 during the active phase, and 15 minutes during transition. Note the changes in the character of the contractions as labor progresses. When the fetal membranes rupture, spontaneously or artificially, assess the fetal heart rate and check the amniotic fluid for color, odor, and amount. Assess the fetal heart rate intermittently or continuously. And during the latent phase of labor, assess the fetal heart rate every 30 to 60 minutes.